Okay, if you guys are ready, we are live.
Welcome, everybody, to the Eureka Springs Hospital Commission Workshop on August 4th, 2025. May we have a roll call, please?
David Carlisle, Commissioner.
Sharon Doremus, Commissioner.
Willie Daniels, Commissioner.
Kate Dreyer, Secretary.
Brian Byler, Vice Chair.
Sandy Martin, Chair.
Tiffany Means, new CEO.
Velvet Schultz from the hospital. Jody Edmondson, HR Director.
First order of business is to welcome Tiffany, our new CEO. We're glad to have you here, and I'm sure you've got everything figured out in the hot 3 hours you've been here. But it just is
It's great. It's great to be here already. I feel the warmth, and it's great. It's really
Awesome. Good. Well, welcome. We're looking forward to your vision and your leadership. That's great. I know the team's excited as well.
good. Thank you.
Just quickly, just 2 sentences of who you are, your experience contributing to the board, because we're real proud of our commission. David?
David Carlisle, retired anesthesiologist, served on various boards as a hospital staff member. Thank you.
Sharon Doremus, former LPN, office setting, and was also a certified tumor registrar with the state of Arkansas.
Willie Daniels, former alcohol drug abuse counselor and child abuse counselor, and also working currently part-time with the Eureka Springs Fire Department as an EMT.
I didn't know that about you. Kate Dreyer, registered nurse, retired, but license is still active. A lot of addiction and psychiatry, case management, Dallas and Santa Fe, and then moved here. So welcome. We're so happy to have you.
Thank you.
Yeah. Brian Byler, basically a layman. I have an insurance background. I do a lot of the Medicare senior stuff, but I'm also a local contractor. My son is a paramedic firefighter, captain of the fire department here in Eureka, and we've been here a long time, since 1985. So just enjoy being on the commission because of being here for so many years and wanting to have a hand in helping make this thing work. So.
Cool. So, and you know me.
Yes.
Oh, that's good. But we're real proud of all the contributions.
Yes.
And each one of the commissioners, we don't have Willie assigned yet, but each one of the commissioners serves on a committee that fits their expertise, which is terrific. Vivian Smith is the missing commissioner. She has years of experience in healthcare administration and marketing in healthcare. And she is, once we get the marketing end of it set up, she'll be participating in that committee and everything. So, great.
Thank you.
Kate, you have an announcement first?
Just a request to the fellow commissioners that there are medical meeting notes quarterly that will be in a folder that Jody will hang on to for us. And if you haven't been upstairs in a while, there's a little space carved out for us that has hot tea and a desk, and it's out of the way for you to go in and look at those notes, and then you'll be signing off on that. And it's a Department of Health requirement that those medical notes, meeting notes be reviewed and then signed off on. So just upstairs to the second floor, and Jody will guide you to the little room. Thank you very much.
Don't get excited about it. It's pretty much of a mess, but it's there. It's got all of our stuff in it. Jody, do you have any updates that you want to share with us?
We are doing onboarding for the laboratory department. It will be staffed 24/7. We just have to get them through orientation and competencies. So by mid-month, we should be covered 24/7.
Great, great. And you are starting to replace independent contractors?
Yes, I was going to let Velvet speak on.
Nice segue, Velvet.
Yeah, we hired 2 full-time nurses. One started actually today, and he starts orientation on Wednesday. He's a 35-year nurse paramedic, used to manage the Air-Evac base in Springdale, critical care background. I actually work with him at the freestanding ER down in Fayetteville, so he's used to a small ER, little resources. He's familiar with several of our staff, and of course the facility and the community. We also hired a second full-time nurse. He's moving here. His mother-in-law lives here. Apparently she's not in poor health. He's coming out of Nebraska, and he won't be here until November. They're trying to get their house sold, but he'll be full-time days, and Kurt will be full-time nights. So that takes out 2 of our contractors. And then we hired a PRN nurse out of Cox Branson, who is PRN down there in their ER and their cath lab, looking to pick up a couple days every other week. And so that, and one of our paramedics is looking to go full-time. So between that person and the PRN person, that wipes out another contract position. So that'll be 3 the next couple months that we'll be able to take out.
That's great. That's real
That's
progress.
wonderful.
Yeah,
Good job.
awesome.
Yeah. Very, very good.
And so how many FTEs will that leave us that we need to fill for, just for nursing?
We will need probably 3 more full-time.
Okay,
Take out the rest of the contractors.
that's doable.
Yeah, and we're going to continue to build the PRN pool. We have 4 more PRN people that have asked, inquired. Some of them have already filled out their apps. Jody's trying to get them set up to interview that are working the various ERs that want to work PRN for us.
That's great. And they may fall in love with us and want to go full-time.
I know, that's what I told them. They would love it.
There you go. Okay.
Super. How's the activity been at the hospital
As far as?
as far as numbers and?
Volume-wise, I can't tell you what I haven't seen any volumes for July, the total number for July. My official be here as many days during the week starts today, actually.
Oh,
My
okay.
commitments elsewhere are done after today.
Okay.
So I would be able to have it. But definitely our volumes continue to, they're minimally doubled of what they have been.
Oh, excellent.
Yeah. We're super excited about that.
Excellent. Very busy.
Good job.
And Cynthia's not here, but do you have any idea of where we're looking at in July?
I have not seen the numbers. I know
Okay.
she was closing out the month, but I
Okay.
have not seen the
Okay.
numbers.
Just curious, because we've had 2 good profitable months, so I'm hoping, and from what Velvet's saying, that it's going to continue. So that's great progress.
Yeah.
Great progress. Any questions for Jody or for Velvet? At all? Okay. Light workshop, one thing is, and I've asked a couple of you, but looks like the council has finally settled on a date and a time for the joint workshop that they've called for. It's August 11th, Monday at 4 o'clock. I know David, Willie, Kate, and Brian can make it. Sharon, can you make it? Excellent. Tiffany will be there with us as well. Jody will not. And I don't know about Cynthia. Tiffany and I will talk to Gabe this afternoon, probably tomorrow, arrange a conference call and go over that. I've asked the mayor to provide us with questions so that we can be prepared and hopefully make the meeting a little bit more productive. I haven't heard anything back, but
No side rail, we're going to try to stay off all the side rails.
I hope so. It's a workshop,
Yeah,
not a special
that's true,
meeting,
that's
so,
true.
and they called it so they can do whatever they want to do. But, hopefully it will be a little bit more focused and productive and congenial.
But subject matter is unknown at this time?
I'm sorry?
Subject matter? Is it
Financials. Is what-
financial work? Okay.
Yeah, and they had questioned the existence of the commission's checking account. Jody and I went through the files. We've got that information. It's existed since 2004 for a variety of reasons, and that's the account that we just closed and shifted over because this commission sees no reason to maintain that. So, but there were really good, solid reasons why it existed in the past. So I have no problem explaining that, at all. And then they had some other questions about aging and other miscellaneous questions. So I'm not quite sure. Hopefully we'll get that list and we'll be able to answer every one of their questions and hopefully be able to move forward with some trust and some confidence and get them introduced to Tiffany and her magic and her leadership style.
Do we feel we've got all the financial information in front of them that they've continued to tell us they didn't have? I think we feel pretty good about that, right?
We provided at the last council meeting on that thumb drive, and the attorney confirmed at that meeting that we had provided everything that they'd asked for prior to that.
Okay.
They brought up in their workshop, they brought up some things that they wanted to see, but they didn't vote on it because you can't vote, so there's no resolution. There were things that I remember from that meeting like aging. They wanted full list of aging. The attorney explained to them that that is a HIPAA violation, but we can give them numbers as far as 30, 60, 90 days. They mentioned contracts. We had provided them with all of our contracts in April, and then you updated it in maybe June when we sent them new batches, but all the contracts we have, they've had. That's all I remember from the meeting, but again, it wasn't a resolution, and I haven't had a formal request. And if they submit one, of course, we'll immediately provide it to them. So they've got the June financials. That was given to them right after our meeting.
I mean, I felt like that at the council meeting that night was pretty much a focus of you haven't provided our information we'd asked for, and I felt like we'd done that, and I just wanted to kind of affirm that thought process.
The only thing that Rochelle brought up was the fact that she didn't know anything about the CD, the commission's checking account. So, fair question. We've got an answer, not a problem.
Who's in charge of the financials for this commission?
Who's in charge of them?
Yeah.
Cynthia Asbury, who was here at the last meeting, I think that you were at, your first one.
Yeah.
Our auditor is Forvis, and if you're not familiar with Forvis, they're one of the world's foremost auditing, accounting, and CPA firms. They're well-known, they're plugged in. They also are healthcare specialists. So our bank of professionals are all healthcare specialists. Forvis is, our attorney is a healthcare, specifically in Arkansas, specialist. Pinnacle IT is a healthcare and a cybersecurity specialist. And they are very strong on HIPAA. In fact, they've got a HIPAA person that watches over us tremendously. And of course, we've got the in-person, in-house person now that is even more alert.
Does Forvis audit the City of Eureka's books as well?
Yes.
Okay.
Yes. Yes. And the other thing that came up at their workshop is they do want to pursue putting out an RFP to get an independent audit of us. Michael Akins, the finance director of the city, counseled them and suggested a kind of a truncated, not a full audit, because that would be expensive, that would take forever. It's not necessary, blah, 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 blah. But there is one that's kind of truncated, that they come and they look at the financials and basically do what anybody can do, with it and give their observations. They did decide to go ahead and have an RFP developed. It's probably going to take anywhere from 3 to 6 months for that process to get it out. They have no idea what the cost is. We, of course, they wanted us to pay for it. I refused to pay for it. So they've got to come up with the money and appropriate that money. Meanwhile, they're off of 2024. They have finally accepted that they probably ought to wait until we get Forvis set up. We will have a special meeting, which means it will be one agenda item. That will be the 2024 audit. Forvis will be here, and they will answer any question and all questions that they have. That hopefully will put 2024 to bed. And so they agreed to that, and then that's why they've shifted their financial curiosity into 2025.
So, since Forvis does the City of Eureka books, and it's the same company that does our books, the hospital's books, audits, has the council in the past then had concerns about the audit results of the City of Eureka?
Not that I know of since I've been here since 2007. That has been brought up by the mayor several times. It's the same company.
Have they, has the council said that they thought that perhaps Forvis had taken a different audit approach to the hospital than they do when they do the city's books, or?
No, they more or less gloss over that topic, and of course, they've got all the Forvis audits that we have. We provided those to them, so no, that doesn't seem to be their focus. Their focus seems to be continuing to dig and find something.
Okay, so you're saying that that Forvis is going to come be here in person
Yes.
at some point to go over the most recent audit, and is it the 2024 audit the only one that the council wants to be reviewed, or do they want 23, 22, 21?
They've got the 2021, 22, and 23 audit.
Mm-hmm.
That nobody has a 24 audit yet, but that meeting will be about the 2024 audit.
And so there will be at least one person from Forvis on site to answer face-to-face questions.
Yes, and remember, legally, we have to present the audits to the city, which we have always done. For some reason, Kent chose not to have Forvis present the last time. That
For 23?
Right, but we are, and Cynthia is trying to get a date. They're still working on the audit, obviously. They think it'll be done sometime this month, but we're looking at probably an early September date. But Cynthia's asked them for a couple of different dates that they feel confident that the audit will be ready, and then we'll float that by council and set up the meeting. And the topic of the special meeting will be the 2024 audit.
Did you have a question? Okay.
Excuse me.
We haven't seen the 24 audit yet
No,
because it's not prepared just yet for presentation.
right. They were in the office until, what, mid-June? Early June?
In fact, Cynthia is on a conference call with them. Cynthia is on a conference call with Forvis right now. That's why she's not here. They're trying to wrap up the audit.
Excellent.
So in times past, since you're a constant for us, 23, 22, 21 in the past, as long as Forvis has been doing our audits, if there are discrepancies that they are concerned about at the end of their investigation, how quickly do they let us know, oh, we need to follow up on this little area over here? In times past, have there been discrepancies that they have needed to follow up on before they do their final presentation? Does that question make sense?
I think so. Not discrepancies. They may have suggestions when they're in-house that they would prefer to see a control outlined in a specific way, which while they're in the house, we do make those adjustments. Each audit will come with a management letter, and they will explain everything they found and what their recommendations or requirements are.
So in times past, it's really just been sort of a format. This is how it would be easier for us to review it in the future if you do it in format A instead of format B, basically.
Yes, ma'am.
Okay. So, all right. So it sounds like that the timeline for Forvis is going along the same rapidity, for lack of a better word, that it has in years past, and there's nothing out of the ordinary.
Yes,
No,
ma'am.
nothing.
Okay.
Nothing.
Very good. Okay.
To your point about adjustments, if you remember the COVID money that we got, and that we had difficulty coming up with receipts from Allegiance Management Company when they were there, to err on the side of caution, Forvis recommended we carry that 3.6 with our liabilities until we're clear of CMS or the Fed's not asking for the money back.
For it back.
So that's why I think it was 22 to 23, I think, that was a journal, adjusted journal entry. That was their recommendation to err on the side of caution, which is correct?
Sure.
So that we're carrying that, that doesn't mean that that's a real liability, but it's a potential liability.
Okay. Thank you, Jolie.
You're welcome.
Anything else? Okay, that's all I have on that topic, I think. The other thing we wanted to bring up is the grant that we have in for the mobile transport / mobile clinic concept. It's all in. I think we find out if we get it in September sometime. Hopefully we will. I think I've passed it around to most of you. Has anybody not seen it?
Did you do it, was it at the flea infestation?
Yeah, I did. Well, there's the whole grant and the thing. And Willie, you had some specific questions that you wanted to ask.
Yeah, basically, is that going to be used for or transfers? Is it going to be staffed by 24 hours? And will those people driving it be EMTs or licensed to do that sort of thing?
Yes, as far as we know, we still have some research to do on that. It was the initial opportunity, the initial necessity was, and you know this is an EMT, our EMS will not take non-emergency transports. That's a huge problem. It's age-old, but it's a bigger problem now that we're REH, because we can't hold them more than 24 hours unless they're for observation. That's 12 hours. They still have to go out. We've unfortunately had to resort a couple of times to Lifeline, which is extremely expensive, completely unnecessary, and we don't get reimbursed necessarily for that. So it's problematic. We use Southern and Good Shepherd as our backups.
And Pafford?
Yeah. Sometimes it might take them 6 hours to get here. But it's a huge problem. So the original solution was a mobile transport van. That kind of morphed into an opportunity, and I think it came from an opportunity that Tiffany and I were talking about, is a mobile health clinic, to be able to go out into the community. That seems like it's even more pertinent now with the changes and with, you know, there's 2,000 people in Carroll County that are projected to lose their insurance coverage with Medicare. It's going to be a serious problem, but if we have a mobile medical clinic to go out, we can do that. I've spoken several times with Gary Inman, our chief, who wants to be helpful and supportive, and of course we're saving him a bunch too. Part of the grant money I put in was training for a community paramedic at North Ark. It's a 2-year course that certifies in that might be an extra employee or might be somebody that we take internally, 1 or 2, and do that. The van as it is, the van as it sits does not require, it's registered as a cargo van, so it doesn't require a special driver or a special license. You can pass that through with it. However, we think we need to register it as an ambulance. That will allow us to do a lot. Yeah. And she's nodding her head, both of them, like, they know a heck of a lot more than I do, so I'll shut up and you say.
So I understand the vision of the mobile clinic and a transport van, but a transport van is night and day difference between an ambulance that can take a sick patient to Northwest Arkansas. A transport van can't do that. This vehicle, in order to transport a patient from the hospital, if that's this goal, has to be an ALS ambulance, an advanced life support ambulance. You can use it as a BLS ambulance for a lesser transport with EMTs, no paramedic, ALS, paramedic, and EMT, okay? And then if you want to use it for a lesser use, mobile clinic, community paramedicine vehicle, whatever you want, you can. You just can't use the lesser vehicle for a more critical reason, but you can use the critical vehicle for a lesser reason. Does that make sense? Sure. So this vehicle would have to be housed inside because it has to stay locked and it has to be climate controlled if we do an ALS type of unit. And this is a requirements for an ALS truck, not looking at the exact model that Sandy's researched and done all the work with. It has to have a strong box for the meds and drugs where it would be removed when the vehicle is stored. Those drugs go back into the hospital and go locked back into the pharmacy. When the truck goes out, it goes back in there. It's called a strong box. Has to be checked every day by the staff, an EMT, paramedic, whoever's doing truck checks. And it has to be licensed by the Department of Health EMS division as an ALS truck in order to transport a patient of ours from the lower level of care to a higher level of care, if that's the goal.
And that is included in the grant application.
Right. But that, for as far as what does it require, it's basically, and there's the rules come under the section of emergency medical services through the Department of Health, and there's a whole list. It talks about lights and sirens, it talks about locks, it talks about the jump seats, it talks about all of those things. It's basically all the requirements of an ambulance. The difference in this truck is it would be considered a non-emergent, non-911 truck. They call it a non-E truck. In Rogers, their former chief, Tom Jenkins, developed a process with dispatch over there. They call it selective dispatch. And this is just one of the thoughts as we're workshopping for this truck. Selective dispatch, when the call comes into 911, the dispatcher goes through a list of questions and determines this is elderly lady in a nursing home who rolled her ankle, who doesn't need lights and sirens, a full ALS unit, 2 paramedics running as fast as they can to jump, grab her, and run her to a hospital. She needs to be picked up, assessed, and then the decision made to take her to lower level care for her ankle. That's a great example as a patient. So in that selective dispatch, Rogers Fire doesn't send one of their ambulances and their crew. They send a contracted company, and I believe they're using Pafford still, as their selective dispatch call. So there's an opportunity with our fire department that would they be willing to look at a selective dispatch process where they're dispatched for the high acuity patient, this truck could be dispatched for the low acuity. I don't know. It would be a way to utilize it when it's not running a truck.
My biggest concern with that in the Carroll County dispatch situation is, can we get someone professional enough behind the mic or behind the answering the phone that can, if they're going to have to make that discernment of a call,
sure,
do we have someone qualified to do that? Because I mean, I know
who dispatches for the fire department?
Carroll County Dispatch. So it's a concern of mine if we're looking at trying to serve. So in looking at the van and knowing that we're going to be looking like at a selective type program, we're going to have concern about who the dispatch side of it, where our qualifications are to make that discernment.
Yeah,
you know,
because you're going to have a dispatch process because even a transport truck has licensed through the Department of Health has to have a dispatch process. Now, is that the hospital dispatch? Is it 911 dispatch? Is it non-911 dispatch? But those records of the incoming call, incoming information has to be collected and given back to the Department of Health collects that information.
So my question there is, like, if we've got paramedics on staff at the hospital, you know, as we do now, if we ended up where we've got someone that has called 911 for help, and then we bring those people into the program, that paramedic at the hospital to say, this person definitely, we can go ahead and go get them with the van. I guess that's where now that you've raised this, I question whether or not we've got the qualified people without involving the hospital, because I think we're going to have to.
Your paramedics are not professional dispatchers.
Okay.
You need a professional dispatch company or organization like Carroll County Dispatch. If you choose to use that truck for selective dispatch, it needs to be a professional dispatcher.
So we're going to have to look hard at, do we have the ability over there to do that with Carroll County Dispatch? I mean, it's something we're going to have to look at hard.
I don't know. I mean, that's just so as you look at ways to use this transport truck, selective dispatch is one of those options.
Okay.
So the question comes back to how do you staff it? The idea is to staff it that we have kind of been laying out there what are our options. One of the options is to put in the hospital, we have 2 clinicians on staff every 12 hours. So there's 2 day shift people, 2 night shift people. We've added a paramedic to be one of those. And so instead of 2 nurses, you have nurse paramedic. At night, you may have a nurse paramedic. And we've been using them, they can't be 2 paramedics ever. One always has to be a nurse and be a paramedic. So we've intermingled them, both for their experience as well as to help with the staffing issues. The 2 that we've hired have done an incredibly great job. It's been an adjustment, I won't lie to you. Getting off a truck for as long as they've been, they have a whole new respect for what we do in the ER, but they've learned a lot. They've got to do things that we've taught them they've never done, and the same for us. If you staff the ER Monday through Friday, 10 to 10, with a paramedic in addition to 2 nurses, in some of the ERs, they call them a mid-shifter. So you bring your mid-shifter in where your volume picks up. You know about 11 o'clock, ER volume is going to pick up. About 9 p.m., it's going to die down, traditionally. So you put your mid-shifter as your paramedic. If there's no transports, he's the extra help in the ER. He's doing whatever list of things that our new CEO has found for us to do. But if they get a transport, you grab the medic, and so who drives for him? One of the ideas is to get EMTs in our community from Inspiration Point, Holiday Island, Grassy Knob, Eureka, wherever, and put them on call with a 30-minute response time. So if we get a transport coming in, your medic's already in-house. He can go out and get the truck warmed up, grab the drug box, figure out where they're going. You get your on-call EMT to drive, and they come in and take the patient wherever they're going. If you're doing an event, you're doing a mobile clinic event, you're doing, community paramedicine or whatever, you have access to this group of EMTs to help the paramedics that the hospital employs. It's just a thought about how do you use them. The struggle always is, especially in the finance world, is, okay, so there's no transports today, there's 3 of them in the hospital, 10 to 10.
We're eating it. Yeah, we're eating it.
Yeah, my CEO will tell you it won't always be the lower volume. But as our volume picks up, that will be better. We've added a 3rd person, started adding them on Saturdays, 11 to 11. And it's been a tremendous help, especially with the increased travel tourist volume right now, and Saturday's a big time, and that's been a big help for them. They'll tell you that our turnaround times are a lot faster. They feel like they're a little more supportive. There's 3 of them there when the volume of the city increases the most. So we've been playing with the mid-shift a little. But if you were going to staff this truck, hiring the paramedics to work Monday through Friday through the week, 10 to 10, is a potential way to be able to do that. If the patient comes in, let's say they come in at midnight and they need to be transported, that's what we put up, that's what we do now. The Pafford, Good Shepherd, and who's the other? Southern.
Right.
Traditionally don't come in the middle of the night. They'll tell you we'll see you in the morning. So we already have that issue. So it's not a whole lot different. We have what we buy is during the day. We don't have increased long ER length of stays. We have a quicker transfer time during the day, but a way to use that truck. Community paramedicine, North Ark has a year program. We could ask either our paramedics or other medics if they would like to commit to us. In nursing school, if I commit to work for a particular hospital, they'll pay for my school with a 2-year commitment, to pay back the money I borrow. If I leave in less than 2 years, they prorate what my school costs and I pay them. It's a way to get a community paramedic of our own who is a paramedic, so they could still work for us, could still get on the trucks, could still be in the ER, but we're headed toward a goal of community paramedic. And then we have EMTs that are used to driving our truck. Your EMTs have to have, there's certain prerequisites, as you well know, your EVOC, your DOT, certain things that they would have to have in order to be able to drive that truck, that ALS truck. Or, I look at it as an ALS truck we can use for everything, not a transport van or a clinic van that we can't use to move a patient from our hospital to another hospital.
So full-blown registers, ambulance, ALS, full-blown.
Yep.
Medical mobile clinic is ancillary.
Yep.
All right, since you've had so much experience in the emergency room stuff, what's your personal feelings about going with that unit? I mean, do you really like the idea? Do you think we've got great potential? I mean, I'm looking at it more as I know it could become additional profit side for the hospital to do the clinics and do that stuff. But the real bottom line is getting the transport of people that need to be transported. That's the reason I think we looked at the van originally, was to help that situation. do we feel like this really has value to what we want to do? I mean, what do you're on it all, you've been involved in it a long time. Do you feel like this could be a real value to us? I mean, I don't know how Rogers, now they're using Stafford? Is that who they're using as their?
Pafford. They use Pafford for their selective dispatch, correct.
So what's your thoughts? What's your feelings about it? Do you like the idea?
As an ER nurse, I like it because I have my own transport. All I got to do is turn and assemble a transport team, in less than an hour, which is what you're used to waiting
Sure.
on pretty much anywhere you go.
Right.
Unless you're going to run a 911, you're going to run a critical transport. It's going to be a little quicker. But from an ER nurse standpoint, yes, I do really like it because I have access to this all the time. Does it help my provider make a decision on whether or not this patient needs to be admitted? Do they need to be transported? Can they go home and then go on their own? Do we send them POV? Are they a fractured humerus and we say, hey, we're going to put this splint on, sign you out, but you're going to go too because it's going to be 7 hours before we can get a truck in here? Right. That's a lot better option.
And so in that situation, someone with that broken arm that can be transported through our program with that van.
100%.
Right? Okay.
100%. You can pretty much, you keep in mind, my paramedic can run lights and sirens. That truck could run 911 if it wanted to. It's equipped to do that. Its purpose is to be a transport truck. The equipment, the education of these paramedics, the way the truck is set up, the licensure, all of that is the same. It's not different. We're just not answering 911 calls.
Yeah, like a third out we use, of course, at the fire department. That's that third out for bringing another group in to run another ambulance because they're overwhelmed with what they're doing.
Right.
This is basically, it's not doing third out. What it's doing is it's taking care of our patients at the hospital that need to be moved instead of calling Eureka or Southern to come get them. We're going to take that step so we can do that in that aspect. If we put the thing in motion in the right direction, we actually will have that capability then.
Yeah, it gives you an additional resource in the city, so you have another medical transport option. Let's say Eureka Fires made a run to Berryville. I heard them go twice already today.
Right.
And they're answering a 911 call out at the edge of the city. And now I got a heart attack, a STEMI that's got to go right now. And I can't get air.
Yeah.
What are you going to do?
Yeah.
You know what I mean? Somebody in that equation is going to have to wait.
Yeah.
Question.
My concern as an administrative world, which I'm sure is what you're about to say, is, okay, what do I do with that extra staff member all day if they don't go on a transport today? Right. Well, in the fire department, that's what you get paid. You get paid to be available. They get paid. Now, can I think of anything for them to do? 100%. I could find something for them to do every single day. You really could. Getting an on-call EMT. The EMTs in our area, no different from any other area, they don't have a lot of other options to work elsewhere. We're not working them in the ER. We're not working them in the hospital. They all work for someone else. They work at this department and then this department, and they on call for this, or they do volunteer. They don't have a lot of options. So sometimes to get them to do things like take call, make a little call money to be available when on their off days is a little easier. But during the day, it's always going to be a challenge to feel like you get your money's worth out of the labor you spend. But when I step back and look at it, if I can take out your 6 travelers, I can afford a paramedic every day.
Absolutely.
And we're still ahead money.
Yeah.
Because what I look at what we're paying our full-time people versus what we're paying travelers, I can pay a full-time person and a paramedic, and still we are less than what we're paying our travelers. And I know that's not an exact science, not exact math, but that's when we step back and look at it. That's what. And then we get We get twice the resource for the city and the hospital.
Question about you mentioned a dispatch service. All of the transports we'd be offering would be from the hospital elsewhere.
Correct.
We would not be going out at any time, as in a 911 call, and bringing ambulatory patients in or something like that. So why do we need a dispatch, a professional dispatch, just to manage the paperwork, in essence?
And to have record of it. To have record of it and make sure the proper information is documented.
Have been met.
Yeah, correct.
Right.
Correct.
Okay.
And it's really a process. And it seems silly to go, the person next to me just called dispatch so that dispatch can call her and say, your transport's on its way. But it's just a way to make it the right process, because the 911 dispatchers are used to that. If you're in Fayetteville right now at the freestanding ER in Fayetteville, and I got a transport going to Mercy Rogers, I call Central EMS, and they say, what do you need? BLS, ALS. And I tell them, they document paperwork, there's a list of documented questions, and I get the same questions every single time. Is the patient breathing? Is the patient have uncontrolled bleeding? Are you with the patient right? There's a list of things they go through, and that's mandatory, and it's just a way to keep that process, a quality metric in that process, to make sure it's done right.
To
Isn't that
having,
part of our-
essentially a physician say this person needs to go wherever,
Correct.
then you have a separate accounting that's done for the.
Well, and this
There's
unit,
a form you fill out that's called medical necessity. That's where that provider will fill that out to say this is medically necessary for this patient to be transported, whether emergent or.
And then it goes into the hopper and gets processed for.
Right.
You start calling whoever's on call.
each party has to have a copy of that. Goes in the
Right.
patient's chart, the transport
Right.
company has to have it. And in that, a patient also can elect for no transport. Well, they have to sign. You understand your physician says it's against medical advice for you to go by private vehicle. We recommend transport. They have to sign that. But this ALS unit needs its own medical director. You got to have a medical director for
Okay,
this
so
truck.
it's a service in and of itself.
In and of itself.
freestanding,
It just is, rolls under the hospital. The basic, there's a lot of, Baxter County and Mountain Home owns their own EMS. The hospital owns that EMS agency. This would be essentially a hospital-owned EMS,
Right.
but it's a transport truck. ALS, BLS
But
transport
the
truck.
rules would apply that it needs to be constituted as an independent unit.
Correct. If it's going to transport a patient
Right.
from a hospital, from a lower level care to higher level care, it has to be registered in the state as an ambulance
Yeah.
with the Department of Health.
And we have to keep that documentation for REH records too, don't we?
So, just being new, a couple of questions. One is, how long is the grant good for?
Everything has to be spent within 2 years.
3?
2.
2. Okay. So I would like to do some research on some similar entities that have something that we're looking into to see what the cost is going to be, what the cost benefit basically. So it would be great if we could come back and I could bring to you a couple of entities if they're willing to share this information. What is the cost to have a selective truck that is basically under the umbrella of their hospital? Because there is a cost associated with that, and sometimes it may just far outweigh more for this 2-year program. It sounds great. I mean, it is a really great thing for rural care to have this ability for the hospital to be able to sponsor this in such a way that we're so far out that, like Velvet had said earlier, this county and the ambulance current district that they're trying to cover is large. And when we're trying to get somebody out safely, maybe non-medical, but it gets them to the care that they needed to go to timely, and then we can move in that manner. But I think that this is something that we need to kind of dive into a little bit more, look to that a little bit more. It's a 2-year grant, so from my experience, you're going to have some investments on the front side that are going to be large, and then you're going to measure that out for 2 years, and that's going to be, is that going to be a cost benefit for us to have, and is it going to serve us in the capacity that we like for it to be served in?
Well, and I think we'll spend this money pretty quickly because the bulk of it is for the actual truck.
Right.
So that's like $210,000.
Yeah.
It's training, and then it's the ALS, it's the, registration with the Department of Health and all that stuff. So I don't think this will stretch out for 2 years.
Yeah.
The only one that would stretch out would be the professional development at North Ark. And that's a 2-year program that, we could do. But I and I don't know how they pay out the money. I think they pay it 100% upfront, but we'll find that out in
Yeah.
a month.
Yeah.
But I'm sensing that this is a good idea, regardless of if we get the grant or not, for the hospital to continue to research and pursue. Is that fair?
I think it's good to research. I think it's diving deeper into the cost benefit. I think that is one, because having it available to us in the manner that we need, it would be a benefit, right? But the costs associated with that, and what's the reimbursement going to be like? So you got to look at some of those things. But yes, I think it's something that is, for me, it's a positive that we're looking at some additional ways for progression for the hospital to serve the community better. So,
Is it billed like a regular ambulance, the same cost? Is it a lesser cost?
Did you see the ambulance itself? Did you see the?
I never saw it. I was gone for.
there's always,
Is it
Medicare, Medicaid, that percentage, you don't get the full reimbursement. So you can bill for it, but that doesn't mean that you're going to fully get that. So we have to look at that piece, and then, what the community predominantly, what the hospital, I haven't looked at the financials enough yet to see what is our current payer rate, what our percentage of the payer rate is in this area.
Oh, there it is.
Well, and those are changing too.
Yeah, and they're changing.
Yeah.
Yes.
Yeah, the whole CMS billing thing's a different issue
Yeah.
on that end of it.
So, Velvet, it seemed I was hearing you explain a higher level of care truck and a lower level of care truck, two avenues for us to consider going down. Is that right?
In the transport world, you either transport ALS, which is advanced life support, or BLS, which is basic life support. Okay. And the difference is ALS is a minimum of one paramedic, if not two. Could be paramedic EMT. And a BLS truck are two EMTs. Okay. Now, could you put a paramedic on a BLS truck? Sure. Okay. But it's going out as a basic life support transport truck.
Okay, so let's say that we chose to do the lesser level of care route, the B route. Am I understanding you to say that even with a B level transport truck, that it would go through the central triage phone of Carroll County?
Yes.
The one professional line that connects with all emergency transportation.
And keep in mind that BLS, if you chose to do BLS, it can't take chest pain, can't take a patient that needs IV meds, can't take a patient with an IV drip, can't take a patient on a pressor, because you don't have a paramedic.
In other words, they're not in an emergency now, but they could convert anywhere on the drive.
Right. So if you take if the physician decides, the ER doc decides, are we going ALS or BLS? The older lady who rolled her ankle that's clearly broken, can't walk, and is going on to the hospital can go with the BLS truck.
That's right.
I've got chest pain, but it's not a STEMI, but I'm headed to the cath lab probably in the morning, but I could change that rhythm in the 2-hour drive to Rogers. Mm-hmm. He needs a paramedic. He needs an ALS truck.
But the triage phone, the people at the triage office, I'll call it, they're the ones making the decision about who needs to pick that person up.
Dispatch helps you make the decision of what kind of truck you're getting. That's what they do now.
Right.
Right now. They would say, what do you need? In our truck, we're always going to have paramedic EMT. So ALS, BLS is really more of a billing thing. You know what I mean? Because the acuity is different of what you're able to provide. But you can go down, you just can't go back up. Does that make sense, Kate?
Okay.
If we say we only want a BLS truck, 2 EMTs, BLS truck.
All right.
Okay, we could find a use for it. We just can't use it 100% of the time we transport. ALS truck, I can use 100% of the time, whether I'm an ankle or a chest pain.
Let's peel off then and bring in some of the things that I've heard of maybe the wish list or how to grow our revenue. And that is a mobile medical clinic, as it were, a medical unit.
Right.
So how is that something that we are wanting to do, and if that is something that we want to have mobile medical clinic out there, do we let the triage people, dispatch people know we have mobile clinic on this day and this day in the coming month, so don't factor us into picking up the lady at the nursing home with the broken ankle?
Well, that's a great question, because that truck is going to need to be available for a transport, whether they're at a clinic doing community
Right, they'll
care
walk the
medicine
clinic.
or they're at the
They'll-
fair doing a, they may have to stop what they're doing and leave and
Yep,
go to a transport.
Yep.
On the other hand,
That's a big
when you
deal.
go back to Brian's question about financially, how do you support this truck? Well, if your medics are community paramedics, they could be in the ER with me, or they could be doing community paramedic visits out in the field. No community paramedic, I say no, I shouldn't say no, I don't do it every day, but it would be unusual for a community paramedic visit to be 2 hours, an hour. They're going in, much like home health, with a very directed goal with their visit. Certain things they're going after, they're going to be in and out. So if I call them and go, hey, we're going to have a transport, needs to go to Rogers, okay, let us finish our visit with Mrs. Means, and then we'll head right to the hospital and pick it up. So they're doing something else instead of sitting looking at me in the hospital. Not that they would be, I know that makes you
Right.
But it being in the ER, not doing a transport, they could be out doing community paramedicine visits. They could be doing a mobile clinic. Even if they're in a clinic, you're not talking about a 10-hour clinic, an 8-hour clinic. You're talking we're going to be there 2 hours, 3 hours. If they know they got to transport, that clinic maybe be cut short. But yet they've served their purpose in giving us an option to transport these patients.
It depends
and
on
if
how
we
you want to
concentrate
set.
in Carroll County, we don't have a lot of travel time. We don't have a
Right.
lot of
Right.
horrible traffic to fight, so it's reasonable, certainly within an hour,
Sure.
to get out of a community event back to the hospital for transport.
And
Or does that not depend on how you want to set your clinic up? I mean, does it necessarily mean that you would only have 1 or 2 patients on a clinic day? I mean, you could have 6 or 7 set up, but if we choose to go down that route, I suppose we have to let everyone know ahead of time, all the patients on clinic day. Now, we've made this appointment with you, but just know that we might have to cancel
which I think would
at
be,
the last minute.
right, I think it'd be a reasonable.
I mean, is that reasonable?
Well, and that's your clinic day that your transport takes 3 hours to go out instead of 8.
1 hour, or 8 hours.
Or longer.
So-
I mean, and again, Kate, just, so when he asked me as an ER nurse, I'm like, I love the idea of having transport at my fingertips. From an administrative standpoint, I want to get as much as I can out of those resources. So we're also stepping over here going, okay, I could use it in the ER. We could do this in the hospital. We could do this in the community. You could do community paramedicine visit. We could do clinic. We could be at the high school. We could be, at this event. We're trying to think of the different things. When
Right.
you think of community events, there's not a ton of community events at 10 o'clock on Tuesday morning.
Yeah.
You know what I mean? There are, but it's a different population than we're doing Saturday all afternoon. But this truck, we're talking about initially proposing Monday through Friday, running during the week to see if we can make that happen. If you staff it 7 days a week, you've expanded your financial outlay a lot, because the weekends are going to cost you a little more for most anybody. Plus, you've expanded going from 5 days to 7 days. So you're not talking about having 2 people, you're talking about probably having 4 people.
So you really don't see that that there being a mobile medical clinic aspect of it is going to really compete for time for the urgent transport?
I honestly don't, but I don't know that I have a very good feel for the need of that community medical clinic.
All right.
Are we talking about, and I know you can't answer, maybe you can't, Sandy, but I don't think we can concretely say, are we going to do vital sign, blood pressure checks on high-risk pregnancy patients?
Or well
Okay.
baby, I don't know.
Right, that's 10 minutes apiece. Even if you got 20 of them, I'm probably not going to be there very long. There's 2 of us, you know what I'm saying? You even have access to some administrative nursing staff that if we know that clinic's going to be heavy today, my CEO is going to have me go and help them, because I'm going to help them move through as fast as I can, because they're a transport truck today. It's like being fire EMS. You may have to go, so let's get this moving. You know, are we doing full-blown assessments, medical histories, medication reconciliation? You know, I mean, I think it depends on the purpose of that rural health clinic and where's the need for it. What is our goal? What service are we hoping to take out there that they can't come to us and get?
Right.
And
it's-
that was the main concept behind that, was to have it as an option, because the priority is the transport.
Right.
And it's easy to schedule or not schedule a mobile clinic, but it complements telehealth as we expand into telehealth. And not knowing what we don't know about what we're going to be dealing with in 2026, it gives us an option to go out there and do that. Gives us an option to get preventative care.
Sure.
And from what I've been researching and understanding about the Rural Health Improvement Program, the $50 billion, half of it's going to be distributed equally to all states. The other half is going to be distributed based on application. Community outreach and increasing accessibility are 2 or 3 of those components in that application. So it's an option. If we don't use it as a mobile clinic the first year, that's fine with me. But just to know that we have it and we can be responsive and we can do education. I never envisioned it to go to a county fair or any of that stuff. This is health clinic, not PR.
Right.
We've got a tent, we've got banners, we've got brochures for that sort of thing. We've got volunteers that can man that. This is really a healthcare concept and accessibility.
And you may find that your benefit comes in the community paramedicine.
Yeah.
That the people that need the service the most can't get to the clinic setting. All the more reason they need the paramedic to come into their house. There's tremendous benefit to see what you eat, how you live, your stairs, your safety, you know, not so different from home health, except for home health gets really limited about who they're able to see.
Oh, yeah. and the
Community
number of visits.
paramedicine,
Right.
you know, the goal for community paramedicine is we are going after this repetitive person we're seeing a lot of how do we keep you from using this 911 resource, using the ER resource, keep you in your home, but give you the care that you need. And you may or may not be able to get to the doctor. Maybe you went last week, but you can't go today. You don't feel like it today, or you can't get to that resource today. But you really don't need a 911 ambulance and an ER visit. You know, and we may find that community paramedicine is the better option.
Yeah.
But we would always have that clinic option. You know, the setup of the vehicle would be.
Parking lot of
It just seems like if we go into it going, we need to think about if we use it for this, 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 and this.
Yeah.
Let's make sure we cover all those bases, and that way we could use it for whatever we need to. Really the key is putting the paramedics in the hospital.
Yeah.
You know, it's been such an enormous benefit for us because they focus on patients very differently than we do as nurses, and it's very interesting to watch them work. But having them as a resource to say, okay, this patient's going to need to be transported. They've already made contact with them. They've got a relationship built with them. They know where we're headed. They know why we're headed there. And that, by theory, that transport out is so much more smoother than 2 perfect strangers rolling up on us after 5 or 6 hours. You can't make anybody happy after 5 or 6 hours. But they're already there and back in the time that the transport companies can get to us now.
Well, my last input on thought here is back to the transport situation. As we look at the profitability side of this thing, you know, one thing that the fire department here in town has continued to look at trying to add a 3rd ambulance. And then we knew about that, and that's when we first started to think about this idea of the hospital having an ambulance for transports. So as we look at the profitability side of it, I think if we work with the fire department and see where we're at with our numbers, I think that will help us understand whether or not this is a profitable investment to move forward in reality, because I know that's one of the biggest things from their perspective. They can't staff another set of people in that fire department they have right now. So therefore, there's a large investment for the city to have to add on or build a fire department in order to have a larger staffing. So that was one thing when we first looked at this a year ago or whenever we first started this thought process. That's probably the biggest thing we look at is the need of the fire department's paramedic and EMS program having that 3rd ambulance available. So that was kind of a...
Yeah, and Gary doesn't think that's going to happen. He has to put 6 people on minimum.
Well, but
Yeah,
is
so that's
that
why
not
we
the,
are-
is
Right.
that not
There's
the
no space to-
opportunity to look at selective dispatch? You know, to take Chief Jenkins and the program that he built in Rogers, he has no financial investment to Pafford EMS. and their 911 they're saving their critical resources in Rogers
Yeah.
and keeping those available, and the non-critical ones, they're passing to this other agency.
Right.
And is that maybe not better than him, I get help in the ER if they're not being used. We get community paramedicine when they're not being used, and he gets a plan B if his 2 trucks are busy. You know what I mean? It certainly is an option.
Now that we've gone to REH, right, now that we've gone to REH, of course, those guys over there, and Willie, their mindset is, I know I may have to transport this person that I'm bringing here to Eureka Hospital in 8 hours or 6 hours from now, I might have to transfer them to Rogers. So again, they're thinking that I got to do a transfer on this person more than likely. So that's the thing that I think there's some, I don't want the Berryville thing, but I just feel like, I know we're being recorded, but I feel like the mindset of some of these paramedics is, I'd rather take them to Berryville to a hospital with beds than bring them over here and then have to transport them again in 6 hours. So I'm throwing that out there as far as thought, that I think we have to look at where those paramedics and firemen are coming from in their mindset. And I think we just need to know that if we do pick up that unit and go with an AL unit, we're going to benefit everybody, but we definitely have to look at the profitability of long-term, because we don't need to take a hit at the hospital for over cost on stuff that isn't going to work. So I imported that with the fact of working with Gary and seeing, are there really numbers here that we can work with that will make this a profitable move for the hospital and benefit the local community?
Well, and clearly we have a lot of education to do.
Yeah.
Well, and is there an opportunity to see what is transported to Berryville? What goes to Berryville that couldn't be taken care of Eureka? I think it would be very minimal, with the exception of patient preference.
And that's, again, knowledge.
As far as physical setup. And so if you shift that back to the Eureka Hospital and you increase the volume, increase the profit, you know what I mean, with that mindset, it's also a satisfier for our EMS guys.
Well, I think as we work with our EMS folks over there, and we have the understanding that is there a little bit of a restriction in the mind, even though they're not encouraging where you're going and they're not making it, it's still the idea that making, again, Eureka the place to go, not only because of our quality of our care, but guys, that's why you want to bring them here. We want to make sure that patient is taken care of, and we can do the job for you.
Sure.
And I just want that mindset that those guys understand that we know what they're thinking, and I may be wrong, but Willie, being around it, I just feel like that with my son and just the things we've shared, I feel like that's a little bit of the hindrance, and they need educated to know that they've got the best place right up here on the hill to take those patients,
Yeah, so that would be the perfect situation if the patient knows that they're going to get the best care going to Eureka Springs Hospital, and they don't need to be transported to Rogers or Berryville. So,
Well, and it answers that question about if the paramedics have it in their head. If I take them to Berryville, it'll save me a trip. We've got that trip covered. So that argument doesn't exist anymore.
No, it does not. But I'm just saying that's a little bit of the teaser thought process that we need to.
Well, and appreciate, that's the same issue you have. Bentonville Fire is its own unit. If the Bentonville Hospital has transport going out, guess who's got to take it? You know what I mean? They have the same issue. Central EMS in Fayetteville has the same issue.
Yep.
They have the isolated contract with Washington County. If you transport a patient out of Washington County, it goes by Central EMS. You do not have an option unless they give it to you. But you have to, so everything they bring in, they take out.
Yeah.
And they know that. But, again, that's just part of it. You know what I mean? You're in a truck for a reason.
Yep, you're right.
Willie, did that answer all your questions?
yes, that's good.
Sharon, any?
Did we ever look at, I know it's impossible to do, but how many people come in through the ER are truly emergencies? And
100% it's easy to look at. Yeah, absolutely. Every patient that enters into the emergency room is instantly assigned an acuity level, a 1 through 5, they call it ESI acuity level. 1 is they're probably not going to survive, 100% they're not, and a 5 is, I'm not sure why you chose the ER for your care, you should be at the doctor, just to give you an idea, and then it's in between. But instantly, in the first few minutes we even see them in the waiting room, they're instantly assigned that acuity level. And of course, you could change it once you get them back, for a minute. But yeah, you can run that report. I can tell Tiffany how many level 1s we've seen, how many level 5s we see on a daily
You've
basis.
looked at these numbers of the people that come in that really, don't need the lights and
Right.
just need the truck to.
Yep. It seems like a lot when you're sitting looking at this really sick patient that Eureka Fire denies to transport. It's really not very many, but one person that has to sit in the ER and doesn't get the next level of care that they need, that doesn't get to the cath lab as fast as they should, or surgery for a belly, a bowel obstruction or ruptured diaphragm or something. When the captain at the fire department is questioning my ER physician saying, this patient needs to go right now, and he says, well, it's not life or limb. Yeah, ruptured diaphragm can be life or limb. Free air is life or limb. But they're helping make that decision. That's very frustrating for us. But the volume that they turn down is not very many, but in the number that we see, it seems like a lot. It's a lot. But all numbers easy together, that we can tell them. We know exactly how many are transported out every day, every week. We run those numbers. We know how many transfers we have, how many incoming we have, how many went home, went to long-term care, went left against medical advice, didn't stay to be treated, whatever it is. We keep track of all of those numbers.
Okay. Dave, any questions?
No.
Kate?
Not about the truck, but if it's a closing question, I just wanted to say to Tiffany that I had seen a collection of governors conference, and our HHS director at the end of his Q&A on stage had mentioned it was at least $10 billion of grant-type money for rural hospitals that, forgive me, I don't know if we had to get our request in by the 1st of September or the end of September. I just remember him saying that if we wanted some of this money as a rural hospital, September came up. And since this was, he was addressing a governor's conference, it made me wonder is it the governor's office that we need to reach out to find out if we qualify as a rural emergency hospital, or if this money for infrastructure and workforce are the two items that he mentioned, if it was for acute care inpatient hospitals only. But with it being such a small window of opportunity to find out, I don't know. Anyway, I'm just throwing it out there for research, and so thanks for letting me bring that up.
To answer your question about the governor, yes, there's some advocacy work we need to do because the $50 billion, that half, goes to the states. They distribute it. So we have a lot of advocacy work to do. We know we'll get portion of the equal distribution, but the non-equal distribution, we're going to have a pretty good plan and request, and so we will need to start wooing and cooing a Little Rock.
So the money you're talking about, that has the September deadline that I...
No, this is
This
not
might
gonna
be something
trigger-
different. That could be more money.
Yeah. Oh, yeah.
Okay. If it's-
I'll look
Yeah.
into that
Okay.
and find out what they've got and what that refers to. What I'm talking about was in the
Something
Budget,
else.
Yeah, the budget
the
bill.
law, $50 billion for,
rural health improvement program, I think it is.
Okay.
But that's 2026.
Okay. No, this is current. So,
Okay.
yeah, maybe we'll get some...
I'll look into it and let you know.
Well, I guess I do have a question. Tiffany, you're planning to look at this whole concept of the van in a kind of a global way in terms of how it'll fit into potential reimbursement and profit and loss and what's available out there.
Right. Right. I'll have that. I'll research it.
Okay, great.
Yep.
Anybody, anything else? Good discussion. Good discussion. Any other questions too? I would suggest directing them to Velvet. Because Sandy's an idiot. And Velvet has a handle on this with it. So sorry, Velvet, but
You're what?
I'm sorry, but
Oh.
you're it, Tag.
If I can't answer it, I'll find someone who can.
No, that's true.
Well, I feel like everything very positive, everything going on with the hirings of all these folks and everything moving in a great direction. So, and again, Tiffany, welcome aboard. And I mean, they've really done a good job trying to lay the groundwork, I think, hopefully to help you in the new transition into the,
Right.
so.
Yeah, it's great. I did rounds this morning with Velvet. I'm going to be meeting with each leader next week. We have a group meeting tomorrow. We are going to be forward motion, and it's going to be some touchdowns happening, and as we kick off the fall festival, and some wins. So I feel very strongly that we're moving in the right direction. And as I toured the ER comparative to where I came from, I can say this: by far, the rooms, all the resources, the staff, they are well equipped comparative to anybody else to serve anybody in emergency away. So I feel strongly that we have a great team, and Velvet working on, and Jody too, working on a lot of steps. It has made me come in going, yes, we can do this. They've had a lot of energies already that have been put in place, and the hospital looks great. On the inside, it looks great. So we're going to be working on a lot of stuff. Yeah.
We're
Good.
excited about that.
Yeah.
And thank you again, Jody, and the crew that's been there, you too, Velvet. Yeoman's job.
Carried the water pails for quite a while, Judy.
You have.
Carried the water
She's happy to give that
I
hat
know.
off
I
today.
haven't seen her smile this much in a year and a half. You're just like giddy. Stop it.
Very excited.
So,
Well, we're so glad you're here.
yes.
Can't wait to
Yes. Yes.
hear your plans, your vision, and we're here to support you and the staff, and you got us.
Yeah.
All right.
All right.
Anybody, anything else? Okay, we will adjourn at 3:17, the workshop, and our next commission meeting is in 2 weeks. It's the 21st, I think. No. Let me see when. It's the 18th at 2 o'clock here at the Odd, and we do have the Commission Council joint workshop Monday at 4 p.m. here at the Odd. Thank you all very much.
Thank you, Sandy.
Oh.